There will be PR segment depression with a concave upwards ST elevation. There will be a left bundle branch block, the bundle exit blocks, or there will be LV aneurysm, a deep QRS with a persistent ST elevations. There may be Brugada-like syndrome where there is a huge, there is no ST segment being seen only, there is a huge ST elevation with a very huge deep T wave inversions, and there may be even early repolarization kind of thing, all can correlate with the ST elevation. LVH can give rise to a norm sort of ST elevation with reciprocal changes or the strain pattern in the lateral leads. You should be thinking of LVH in all those conditions. Bundle branch block, you also know. Zagabos criteria is one of the important criteria. Like if you have a bundle branch block, then the condition where you can suspect that patient is having MI if the chest pain is there, that a concordant lead being having, if the concordant lead has a ST elevation even more than 1 millimeter, then it is positive. It is one. It carries about 5 points. If the non-concordant, like the QRS and ST are dissociated, and you have a more than 5 millimeter ST elevation, then it carries around 2 points. If the ST elevation is more than 5 millimeter, if ST depression is there along with the concordance with the QRS, then it carries a 2 points. Here you should always go with this criteria. The actually Zagabosa has been given these 3 criteria, 5 criteria of 8 point criteria, but most sensitive and most specific are usually nowadays what is used is only this criteria, that is ST elevation in the concordant lead more than 1 millimeter is usually considered as ST elevation MI in presence of left bundle branch block. So here is a classic example of LBBB left bundle branch block. The ST elevation appears to be more than 5 millimeter but not sensitive. Even this one is also showing about 2 millimeter, but there are no leads in which concordant elevation of ST elevation is there. So it's not that much accurate for any of the MI. It's only the left bundle branch block. Other than that, nothing else can be depicted from this. Here is also similarly the left bundle branch block. There are no ST elevations. ST depressions are there, not particularly of more than 2 millimeter, and also there is no concordant ST elevation is also not seen. Okay, even in paced rhythm the same criteria is fixed. So paced rhythm also, if you can get a ST elevation in the concordant lead, then it will be considered as ST elevation. Here you can see there is a RBBB with ST elevation of being 2-3 millimeters in the lateral leads. That is considered as a absolute ST elevation MI. If these changes are there in the presence of LBBB, the concordant leads show a ST elevation like this, then it is called as ST elevation in presence of bundle branch block. The other causes of ST elevation are being pericarditis. You should first look for the PR segmented lead V1 and lead 2. If they are depressed, and then it's a concave upward ST segment elevation, that's most probably you are dealing with pericarditis. See the PR depressions in the V1, V2, V3, V4, and a concave upwards ST elevation in the V5, V6. You can see that. So this is what is the actual depiction. This is the concave upwards and this is the convex upwards MI. So always remember, early repolarization is usually very commonly seen in the V1, V3 leads, and it should be like the displacement is commonly 1 to 2 millimeter, and it should not be more than 25% of the T waves. If it is more than 25% of the T wave, we should be suspecting MI. So these are benign early repolarization, not more than the 24% of the ST elevation, the predominant T waves. Brugada syndrome is another very important thing, where the pattern may be like code or saddle shaped or biphasic T waves can be seen. That is type 1, type 2, type 3 are considered. If the patient doesn't have chest pain and if it gets triggered by antiarrhythmic drugs, these ECG changes are seen, then most probably you are dealing with the Brugada syndrome. This V1 is type 1 is ST elevation, a downsloping ST segment, inverted T waves may be seen, that is biphasic ST segment. If the type 2, it's a saddle back appearance, STT config upright or biphasic T waves are seen. So this is one of the classic examples of Brugada syndrome. ECG is showing a huge ST elevations in V1, V2, V3, but As you can see, the patient doesn't have any chest pain, and also the other lead, the reciprocal changes are not seen in the any of the leads. This is one of the another example for huge ST elevation with acute chest pain is the Takotsubo syndrome. There is a non territorial ST elevation can be seen. All the ST elevations in B4, B5, B6, and even 2, 3 AVF and all elevations are seen. So it's most probably